We're now recording. I'd like to introduce myself. My name is Kelly Shield. I'm a nursing home administrator, and I am also at Partner Care Pharmacy. And with me, I have Adeline Mieles, who's going to introduce herself.
Hi, nice to see you again. Hi, my name is Adeline. I'm the pharmacy director, and I'm also a consultant pharmacist. And I'm going to give you some details about Medpass during these presentations.
We're going to share the screen now. These are the learner objectives for prevention of medical errors. This course satisfies the Florida Department of Nursing and Nursing Home Administrators and CNA's requirement for 2 CEUs of prevention of medical errors. The presentation has also been updated to include recent licensure survey trends and also information on pandemic nursing. As a reminder, this course is for medical errors, not medication errors. Although medication errors are part of all errors, this has been expanded and is not only limited to medication errors. A good place to begin talking about errors in nursing homes is the OIG report on adverse incidents and errors in the skilled nursing environment. The Office of Inspector General was mandated to create this report and stated the need to focus on nursing homes, saying, although in recent years, various studies have paid substantial attention to patient safety in hospitals, less is known about resident safety in nursing homes. So the information we're providing to you today includes a lot of specific nursing home error information. The sample for this study looked at a SNF stays of 35 days or less. So it's a picture of a 1-month stay in a nursing home. The findings included that 22,000 post-acute Medicare patients experienced at least one adverse event during their stay. A smaller portion of patients experienced more than one adverse event, 2.6%. 1.5% of skilled nursing patients died as a result of adverse events. This rate projects to an estimate of 1,500 SNF residents that an adverse event contributed to their death during the study month. Resident care events that contributed to death included blood clots, such as DVT, fluid imbalances, and acute renal insufficiency. Medication events included excessive bleeding due to anticoagulants and acute hypoglycemia. Most of these residents died at hospitals rather than in SNFs where the harm occurred, having been transferred back to the hospital for a higher level of treatment. The term adverse event describes harm to a patient or resident as a result of medical care. An adverse event includes the failure to provide needed care and also medical errors that are a result of general substandard care. Some of the examples of harm include infection caused by contaminated equipment. However, adverse events do not always involve error, negligence, or poor quality of care and are not always preventable. 22% of patients experience adverse events.
I gotta go.
All right. If you have 30 new patients a month, 22% means 6 of those patients will have an adverse event, even though adverse events do not always result in harm to the patient. The National Coordinating Council for Medication Errors Reporting and Prevention Index was developed to categorize when errors go from no harm to harm. So 1 in 3 patients in skilled nursing facilities suffered from these types of medical errors. Events related to medication includes medication-induced delirium or change in mental status, excess bleeding due to medication, such as
antidepressants like fluoxetine. It inhibits the metabolism of warfarin, and anticoagulants like heparin, antiplatelets like aspirin and Plavix.
Infections include aspiration pneumonia and respiratory infections, surgical site infections, UTIs, and C. diff. And other types of harm include falls with injuries. What is preventable? If it is due to one of the following, it is categorized as preventable: substandard treatment, inadequate resident monitoring, failure to provide care, and delay of necessary care. You need to make sure one of the examples of failure to provide care is having an adequate influenza and pneumococcal vaccination program. Among the preventable events, 37% involved inadequate monitoring of residents. One sample resident suffered from an undiagnosed collapsed lung because the staff failure to recognize symptoms of shoulder pain and shortness of breath. The resident later had 2 additional events, a reaction to medication and a blood clot, both requiring transfer to a hospital. Non-preventable events. 59% of adverse events are non-preventable. In other cases, resident care decisions made in a prior hospitalization resulted in harm during the SNF stay. So when the SNF accepted the patient, it was already on a downward trend. In one case, a resident developed a full body rash several days into the stay that was an allergic reaction to an antibiotic that had been prescribed in the preceding hospitalization and was continued in the SNF. In other cases of non-preventable adverse events, the SNF residents or families contributed to events by being non-compliant with staff recommendations. For example, one resident with Alzheimer's-related dementia fractured his hip while attempting to stand without assistance. And another resident pulled out his feeding tube, ultimately causing an infection at the insertion site. So it's good to point out that all adverse events are not preventable and are not the cause of nursing error. We mention this because it's important also to report when errors happen. This isn't about blame, it's about corrections. Non-preventable errors found in the study, patients were highly susceptible, Patients were highly susceptible to events because of their health status, incorrect assessments, patients' diagnoses are unusual or complex, making care difficult, and care provider could not have anticipated the event given information available, meaning the history was not complete. When we talk about what is preventable, appropriate treatment provided in the substandard way, not following doctor's orders or the facility's own policies and procedures, patient progress not adequately monitored, necessary treatment not provided, missing doses of medications perhaps, poor medical judgment. This is true with a lot of new nurses that are new to the profession and nurses that are new to the skilled nursing environment. The patient care plan does not address risks. The care plan is incomplete and the patient's health status is not adequately assessed. So preventable errors in the skilled nursing environment can be boiled down to assessment, patient care plan, and proper medical judgment. This is a graph that looks at the reasons for all of these preventable errors that were found in the study. And as you can see, over 30% are substandard care, 25% is inadequate monitoring. These were the rates of adverse events in the skilled nursing facility environment. 21 in 100 admissions had an adverse event, and 16 in 100 led to harm events. And we'll talk about when you go from no harm to harm in the next slide. This is the NCC MERP index for categorizing errors. Adeline, will you explain this?
For the study, only level F to I harm reached the patient. Events were reported. AB does not reach the patient. This can be like pick the incorrect drug and notice before the administration. In C, error occurred that reached the patient. Patient take the medication, but it's not harmful. For example, giving a patient a vitamin C, it would not cause any harm, but it was not intended for that patient. Letter D, error occurred that it reached the patient or resident and require monitoring to preclude harm or confirm that it caused no harm. In these cases, patients require monitoring from blood pressure or glucose to confirm harm. We can think about administer an insulin or antihypertensive agent to a patient that's not needed. But how about toxicity with vancomycin or aminoglycoside antibiotics due to nephrotoxicity or ototoxicity? That is part of good monitoring. Error document that may have contributed to or result in temporary harm. Patient that requires intervention, example that need oxygen, that need the insulin shot staff or other type of medication. Errors that require prolonged facility stay, administration of a medication that caused sedation and it was administered instead of a bedtime was given during the day, and this caused the patient to fall, and then the patient cannot leave a facility because now it has another harm that it wasn't the one that when he came to the facility because the medication was administered at the wrong time. Permanent harm can be in stroke. If that same patient that fall can have a stroke due to that fall, and that can cause another type of harm on the patient. And requires intervention to sustain life CPR or intubation. That same patient again, the patient fall, has a stroke, and now the patient needs CPR or intubation because the fall was so bad that the patient needs another intervention to sustain life.
Let's look at this case study that will give you an example when errors go from no harm to harm. We will also look at the red flags that nurses should stop to prevent a cascade of errors. Mrs. Wright was admitted to the skilled nursing facility with a diagnosis of lung cancer. The charge nurse noted that Ms. Wright was anxious and agitated and called the doctor. The doctor ordered Haldol. When the charge nurse retrieved the medication from the emergency kit, she was distracted by a phone call and she selected the wrong drug. She took out Halcion on mistake. This is a level of B because the drug was taken out on mistake, but it had not yet reached the patient. There was still a chance for this error to be discovered and stopped. But what is the red flag in this case? The nurse was distracted because she was had a phone call and was trying to multitask. Ms. Wright refused the Halcion pill, saying they were the wrong color and size. Eventually, she relented and took the medication. This rises to the level of C, reaches the patient but no harm, because at this point there are no contraindications for the patient receiving this medication. But there's another red flag. Do you know what it is? Listen to your patient. If your patient refuses to take a medication, especially if it's a new patient that you're not familiar with, that should be a warning sign. At Medpass, Ms. Wright took all her nighttime medications. Included in those medications was Dilaudid for the lung cancer. The combination of Halcion and Dilaudid could be fatal. This is where we cross over from no harm to harm, because now it requires monitoring. The patient has 2 medications that are contraindicated. During rounds later, Ms. Wright was short of breath. The nurse administered oxygen and called 911. This reaches the level of E. It requires the intervention of oxygen and also calling 911. Ms. Wright was sent to the emergency room. She went into cardiac distress and was given CPR. Here we go further into the harm categories. F, requiring transfer to a higher level of care, and H, receiving CPR as an intervention to sustain life. There's also a red flag here. Was Ms. Wright a DNR? Did the nurse overlook it? A lot of times, especially with new admissions, these aren't things that you know offhand and can lead to also a further error of not following DNR statuses. After 60 minutes of CPR, Ms. Wright was declared dead. And remember, 1.5% of patients die in nursing homes because of medical errors. This is the highest level of harm, I, an event that contributed to the patient's death. And as the study found, the patient was transferred to a hospital, and many times that's where the resulting fatal event happens. So where did it all go wrong? What was the first error that happened? The nurse selected the wrong drug. Second, she didn't listen to the patient's protests of not wanting to take the medication. The third error was she gave the adverse drug, Dilaudid. And the last error was the delay of response or failure to monitor to the adverse event because she gave her medication and then left the room. It's important that when you recognize an error, yours or your coworkers, to stop and point it out. By recognizing the first error, you can prevent the second error and then the cascade of errors. Factors that impact the occurrence of medical errors. This is from the National Institute of Health and Safety. The number one factor is human error. Since we are human, we do make errors. The second factor is being distracted, multitasking. The third is the environment that many nurses find themselves working in that is stressed and overloaded. And the last impact is a new nurse, a nurse that is new to the profession or new to the long-term care environment. So let's control the environment. If you want to reduce errors, the first place to start is to control those things that you can, including your working environment. Nurses' stations can be high stress settings. What distractions do you have in your facility at your nurse's station? What are the interruptions you have to deal with when you should not be multitasking during Medpass or taking orders? Shift changes that are rushed or when you are tired translates into poor communication that also can lead to errors. Medication errors can be attributed to shift changes and workload increases. Your workspace should remain uncluttered. If we could give you one piece of advice that would help you reduce your errors right away with not a lot of intervention, it is to clean your stations, Organize your stations. There have been recent citations given for storing equipment in stations and having a messy station. A messy station leads to disorganization and sloppy mistakes. Reduce interruptions, as difficult as that can be. If you're in the middle of an important task and someone is trying to interrupt you, ask them to wait. And do not multitask. Put your phone away. Do not text, do not Instagram while you're on duty. When we talk about controlling the environment, we also recognize when you don't have any control over your environment in such instances as the pandemic. During emergencies like hurricanes, we lose the ability to control many things in our environment, and our priorities shift to dealing with the crisis at hand. It's been a long, stressful, and exhausting year, and pandemic nursing environments must be addressed to reduce errors.
You are mothers, fathers, daughters, sons, family. What you've done for others is extraordinary. You gave up getting hugs when you got home, if you went home. You gave up your own room to a lonely spare bed and isolation. Dinner with your family. Dinner, period. You gave up nights, weekends, and nights and weekends. And as always, you gave of yourself because complete strangers needed you. To our clinicians, nurses, researchers, technicians, support services, everyone in service to our patients. You know you gave up a lot, but you never, ever gave in. It's who you are. It's who we are. And we're stronger together.
So let's look at pandemic nursing. A recent article by the Institute for Safe Medication Practices reported a serious increase in medical errors. It also found another disturbing trend, that under pandemic nursing environments, nurses try to hide their mistakes. Pandemic nursing environment can be described as rushed, physically overwhelming, and emotionally draining, coupled with an onslaught of critically ill patients with diseases you're unfamiliar with, and staff shortages due to call-ins. Communication is compromised due to canceling daily meetings and rushed endorsements. We have seen this in recent survey trends where control counts used to be something that was routinely done is maybe something that isn't routinely done during this time. During a crisis such as a hurricane or a pandemic, staff members need more communication, not less. High-risk situations lead to errors. Are you facing pandemic nursing? Are you working in that environment? The signs of working in a pandemic nursing environment include frantic pace, adrenaline pumping reactions, daily crises, and new procedures that are constantly changing. You can compare the COVID environment to a hurricane, but a hurricane only lasts 10 days, and you have been doing this for over a year. What can we do to address the errors that come with working in a pandemic nursing environment? The first thing is to go back to basics, go back to endorsements, go back to counting pill by pill, and do the things that are, although maybe the first to fall off the list of important priorities, need to be put back there. The second is to train and retrain nursing staff, again, on the basics, and today we're doing that. Reinforce reporting. This is not a time to judge others. It's a time to target your errors, to create improvement plans to get better. An open and honest work culture where you encourage your nurses to report errors is what is needed at this time. And finally, organize your work environment. National Patient Safety Goals. These are from the Joint Commission, and these are the same types of goals that we have looked at the National Institute for Safety, but these come from Joint Commission if you're Joint Commission accredited. Improve the accuracies of patient resident identification. Improve the safety of using medications. Reduce healthcare associated infections. Reduce patient resident harm from falls, and prevent healthcare associated pressure ulcers. Here are the 5 steps of the prescription process.
There are 5 steps and therefore 5 opportunities for errors. There is prescribing, transcribing, processing, administering, and monitoring. Prescribing. During prescribing a step is while you're receiving orders by telephone from prescribers. It can happen errors of omissions, incomplete and unclear orders, wrong time of administration or frequency, wrong dose, forget patient's allergies, or give the incorrect patient name. This is very important that you know your resident and be ready with the correct information before calling a doctor for an order. Read what you wrote to the person given the medication order before you move forward to confirm that what you hear was the correct order for that patient. Very important, again, know your resident, know the allergies. If you don't have the correct information on hand for the prescriber can make a wrong decision on a therapy for a patient. When we're talking about transcribing, it refers to any deviation during the transfer of the information received. It can be verbal or it can be written. If we made a mistake of what we hear from the doctor in paper and we send that to the pharmacy, that is an error that the pharmacy can make a mistake. And when we return to the facility, it can be a medical error because the wrong medication or the wrong dose or the wrong frequency was given to the patient because of an error in transcribing. And this is very common when we receive admissions from other facilities or other hospitals that we are in a rush transcribing written orders. When we talk about processing, this is referred when a medication is removed from the original package. It can be removed from the bingo card. It can be when we are withdrawing insulin from a vial. And it can cause a harm to the patient because we do the improper manipulation of the medication. Administering, very important. And it's gonna go over all the slides practically. Remember the 6 rights: the right patient, the right drug, the right dose, the right route, right time of administration, and right documentation. And this is, again, when you are in a pandemic situation like we were recently, it's very important that we go back to basics and we don't forget any of the steps of medication administration. And the last one is the monitoring. Failure to monitor meds, therapy for efficacy or toxicity may result in treatment failure or an unrecognized drug adverse reaction. I can give some examples about lab monitoring for vancomycin, blood sugar not checked, and if it's checked, the nurse didn't react properly, or the nurse react but give the incorrect amount of insulin according to the sliding scale that was provided for the patient. In medication error quality initiative, there are some examples of medication errors that can be added to quality initiative that can be implemented in the facilities and avoid them to happen. Very important, do check of expiration date of insulins after open. Remember, insulin has 28 days after opening. Evaluate documentation on the mark. Look for the medication if it was given and document it. Verify if it was administered and not documented. Very important to document immediately administering the medications. For example, do a stop and clarify the difference between the document administration of a narcotic or a controlled substance. When we document in the Merp, we document the administration of the medication. When you document in the narcotic log, you're documenting the removal of the narcotic. There are two different types of documentation in the process of administration medication. Very important, when we remove a narcotic from a bingo card, we immediately document in the logbook. That doesn't mean that you give the medication to the patient. That means that you are removing something from the inventory, and you need to have a good balance between what you have physically and what you have in your log. And the documentation on the Merp is that you actually give the medication to the patient.
Is that it? The recent survey. Here are some recent survey trends that we have found that we would like to give special attention to. Controlled substances. It's important to resolve any discrepancies immediately. If you find a discrepancy in controlled substances, you need to report it and not endorse it to the next shift. In a recent example, it was 2 days before it was able to be discovered when the first time the discrepancy was found. This is very important to make sure that it's reported immediately and handled and resolved at the same time and not endorsed to the next shift. The correct procedure for controlled substances is remove drug, administer, and document. And Adeline just went over that. It is not document, remove drug, administer. That's where you're going to find yourself getting into trouble. If the documentation is done and a surveyor looks at the documentation and the drug hasn't been administered, then that's incorrect and it will result in a citation. Document the time given for controlled substances and make sure you properly dispose of any narcotics. Also, expired drugs. Make it a habit to look at expiration dates, especially for PRN medications, and make sure the drug is not expired. A lot of times PRN medications can linger in a cart because you don't use it that often. So when you pull those out, just make a habit of looking at the expired drugs. Labeling and storage. Adeline went over the insulin. There's stickers on insulins for open date and discard date. And these are being scrutinized by surveyors. They go right to your med cart and they're going to be looking at these insulin expiration dates. Personal effects in the narcotic drawer. Do not put watches, wallets, cell phones, money in your narcotic drawer. Give them to social services the minute you receive them from the patient. Make sure you check your refrigerator temps. Lock your carts and don't put drugs on top of your cart. Make sure your stations are clean. And also, Adeline is going to go over hand washing procedures. It can be very tricky, especially when somebody is watching you wash your hands, but making sure that medication is always within your sight, even when you're washing your hands. Medpass 101. Adeline?
Before you start your Medpass, get prepared. Professionalism is very important. Make sure that you have your identification. Always look professional. Organize your med card in advance. Secure all your medications. And again, remember the 6 rights. Respect resident rights and privacy. Knock on the door before you enter. Never give medications in common areas. Give the patient privacy and avoid any embarrassment and any breach of resident confidentiality. Your med cards are really, really important. Everything that you have in your med card is because it's part of your medication administration process. Only food and beverage used for the medication class are the ones that should be in your med card. All food and beverage should be labeled with dates and time open. There shouldn't be expired. The best practice is to have fresh fruit fresh food every single day, especially the applesauce. Regarding waters, make sure that it's labeled with the date and avoid any change in color, any particulate. Try to change that water every single day to have a nice, clean, and fresh water for your residents. Protect against contamination. All food, beverage, and straws should be covered. Spoons and mixers handles up, med and water cups rings down, and not touching contained surfaces. Very important that you cover all your supplies that you have in your med cart. Anybody can pass by and take something from your med cart because they want a little bit of water or they need a spoon, and maybe they have their hands contaminated and they touch the spoon that you have for your residents, and they can transfer any microorganism to the spoon that you are gonna use to administer medication to your patients. Don't allow refrigerated items to remain on the cart, especially insulins. Remember that insulins, even though they are unopened, if you exposing them to room temperature, the expiration date will be reduced to 28 days. That is what is important, that all your insulins that are closed remains on the refrigerator. Medication administration. While doing medication administration, keep in mind infection control. This includes that the device that you use are always clean. That means your pill crushers, your glucometers. Make sure that you have soap and hand sanitizer available. That you don't have to rush in looking for soap everywhere or hand sanitizer. Practice always proper hygiene technique and put a barrier between the room table and the tray for the meds. Do not leave the medication unattended, but do not take the medications to the bathroom. Always keep your eyes on the medication. There is always a little table that you can move next to you while you are doing your hand washing routine, but never leave the medications unattended. Once you are ready to administer the medications to the resident, proceed to perform your hand hygiene. A simple slide that I found from the CDC, it shows your hands are really dirty all the time, especially when we are working with meds and working with patients. Then wet your hands. Then put your soap and then scrub, 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 like for 20 seconds if possible. Not if possible, for 20 seconds or more. If you need to sing happy birthday 30 times, sing happy birthday 30 times because it's gonna be 20 seconds depending on how fast you are singing. So it's better sometimes to count from 1 to 30 very slowly. After you scrub for 20 to 30 seconds, rinse your hands with clean water and then close the faucet with a clean towel and dries your hand. Now you're ready to give the medications to your residents. During medication administration, there are things that you need to remember. Never touch the pills. If by any chance you need to touch the pills, use gloves. Always pop pills from the bottles packed over the cart or at the bingo cards. Do not remove the tablets outside the bingo card, outside the med card. Why? If something falls on the floor, you need to throw it away. If this is narcotic, you cannot throw it away. You need to call another nurse or your supervisor to make the proper disposal of that narcotic. You will have to document and you will have to have a witness when wasting a narcotic. The best practice is to follow your facility policy regarding
narcotic disposal.
Narcotic disposal. Be sure that only spirit tablets are allowed to be split. If you have an order to crush medications, use a pill crusher. And you're gonna put the medication that you crush in applesauce or in water if it's a G2. And then you're gonna administer to the patient. Remember that not all medication that has a score in the middle can be crushed. especially the metoprolol succinate, that's the topro, is a medication that is scored. It can be cut in half, but it cannot be crushed. And be certain to shake liquids before putting and clean the drips from the bottle. They can cause very messy med cards if you don't clean those bottles properly. While you give an administration of medication through PEG tube, always check the placement of the tube. Administer each medication separately. Crush only those medications that are immediate release. Again, they are medications that are sustained release or enteric coating that should not be crushed. Sometimes they can clog the PEG tube. If the medication cones is liquid, try to get it in liquid. Flush with 10 ml of water between medication, and once you finish, flush the PEG tube with 30 ml of water. When you administer oral inhalers, most of them are used for asthma or COPD. Wait 1 minute between puff and rinse the resident mouth after those are administered, especially for those that are corticosteroid, because they can cause fungi in patients' mouth, like Candida. In ophthalmic preparations, always use a tissue with gloves and ask the resident to look up. Do not touch the eye with the dropper. Wait at least 5 minutes before administer another drop. For otics preparation, always use gloves when administering the ear drops. Have the resident to lie down with the affected ear up. Pull back the earlobe and instill the drop without touching the dropper to the skin. Instruct the resident to remain in position approximately 5 to 10 minutes with the affected ear upward. This is a slide that I prepared for self-administration on assisted living facilities. I think that it's important that we share with them because some of them can be working at assisted living facilities. In section 429.256, section 3 of the Florida statutes has some tasks that can be allowed while doing assistance of self-administration of medication. Between those are taking the medication in its previously dispensed, properly labeled container for its store, and bringing to the resident. The person that work in the assisted living facility, especially if they are med tech, they are allowed to take the medication, put it from the bottle, and give it in the hands to the patient. This can be used, they can be poured in a little cup and give it to the patient, but not administer the medication. In the presence of the resident, she needs or he needs to read the label, open the container, and then removing the prescribed amount of medication and closing the container. Can assist with administration of an inhaler or nebulizer. This means that it can remove the cap of the nebulizer, it can open the unit and pour the prescribed measurement dose of the medication. It can assist with topical medication and keep record when assistant receive an assistance with self-administration. But there are some things that also cannot be done. In the same section, section 4, it says that the medication, that the person that work with self-administration cannot mix, compound, or calculate medication dosages except for measuring a prescribed amount of liquid medication. This means that the technician can measure 5 ml, 4 ml, that is the amount prescribed from the doctor. But they cannot calculate doses to give it to the patient. Preparation of syringes for injection or administration by injectable route, those are things that cannot be done during self-administration process. Provide or administer rectal, urethral, or vaginal preparations. and assist with medication ordered by the physician or healthcare professional with prescriptive authority to be given as needed. When medication are given as needed, for technician give the medication, it has to be under a specific parameter. It's very important that all the PRN's medications has a specific parameters so the medtechs can administer or give the medication to the patient. If it's blood pressure, it has to have parameters in there. If it's something for pain, it has to specify pain and the level of pain. If it's for allergy, it has to specify what type of allergy. That is the only way where PRNs can be administered with a med technician. Very important to remember in an inspection. Remember, be calm. There is no need to rush. Slow down. Wash your hands. Wash and wash and wash and wash and wash your hands before and after medication administration. Keep the medications always at your side. Double check with your supervisor insulin units before administration. Sometimes the orders were handwriting and cannot be read very good. So always consult if you have doubts. Sign your mark at the end of Medpass, not before. Know your residents. That way you know if the medication, if you took a medication by mistake and it's not for that resident, if you know the resident, you should avoid, you can avoid harm to a patient because given the incorrect drug. When in doubt, said, I will get back to you with the answer. You don't have to answer inspection questions exactly at the moment that they are asking for it. The Institute for Safe Medication Practice has lists of errors from abbreviation. When transcribing prescriptions, do not use abbreviation. This is a safe medication practice. Some examples is to avoid the use of QD. QD can be confused with QID, that is 4 times daily. Instead of giving the medication daily, it can be confused and given 4 times daily. The units of insulin, avoid the use of the U and try to write always units. It can be mistaken by a 4 or a 0. And do not abbreviate name of medication and strength. For example, milliliters and milligrams. Try to write the complete word. Another safe medication practice is look-alike, sound-alike medications. When in doubt, just ask. If you don't understand what is in the order or you're not familiar with the medication or the treatment, ask. There is no bad thing in asking. Here in the pharmacy, we use all the eyes of all the pharmacists when we are in doubt, if we don't understand something. And between us, we cannot figure out what is the order. We call the nurse or we call the prescriber. But it's very important that not to be afraid to ask when you are in doubt. When you make a mistake, take a mental note of what you did and try to avoid that mistake to happen again. For commonly confused med, ask another person to double check the product. Errors with high alert medication will almost always lead to significant harm for the patient, even when it's used as intended. Even that we are using the medication the correct way or giving the medication the correct way to the resident, consequences may be devastating. The top 5 high alert medications are the narcotics, the injectable potassium, the injectable anticoagulants, and the sodium chloride about 0.9%. Medication triggers.
This is a list of medication triggers that also we can call red flags. These are mistakes that happen, and they're in order of the most common to the least common. So abnormal electrolytes, abrupt medication stop. If you run out of medication and the patient goes several doses, misses several doses. Following through, all of these triggers, you should make a mental note of them because they will lead to medication errors.
Some examples, it can be elevate INR in residence. Elevate INR in residence can be a factor for drug interaction. So if you have elevated INRs, that's a red flag. Why we're having so many INRs elevated? Another good example is the administration of naloxone. That is a trigger that can help identify instances where a patient was given a harmful dose of an opioid drug. So each of them, if you notice a high tendency, that's a red flag. So you need to take action and evaluate why is the reason those values are so high.
So it's the precursor to the adverse incident. This is the warning sign that you should take this list and copy it, especially the directors of nursing and the assistant directors of nursing, to make sure that you're looking out for these triggers. Other medical errors includes infection. It's the second most common errors that are in skilled nursing facilities. Risk factors that predispose older adults to infection have been well described and include the presence of indwelling devices such as feeding tubes and catheters, recent admission to acute care facilities because they are coming from another setting. They can be carrying infections. Functional impairment, it's difficult sometimes to identify infections in patients that are cognitively or functionally impaired because you don't see any change in their status. For example, nursing home residents with feeding tubes are susceptible to aspiration pneumonia in 15 to 23% of instances, local skin and soft tissue infections, as well as other mechanical complications. The unique challenges for infection control. There's emerging infections, and as we talk about this, we cannot ignore COVID as the top emerging infection. Antibiotic-resistant organisms that are in institutional environments, and also overuse of antimicrobials. This is something that your antibiotic stewardship program that should be looking at every single month. Risk factors for antibiotic resistance include advanced age, decreased functional status. The longer you're in the facility, the higher you're at risk. Prior antibiotic exposure, long treatments of antibiotics and different treatments with antibiotics, indwelling devices such as catheters, and also comorbidities, which is more than 2 chronic diseases. I think that could probably describe many of our nursing home residents. The antibiotic-resistant organisms in nursing homes. Use of antibiotics is the key reason for the emergence of antibiotic-resistant organisms, and that's why antibiotic stewardship programs are very important. Patients also serve as vectors going from one facility, acute care setting, to nursing home, and they bring their antibiotic-resistant organisms with them. They're a very challenging host. The most common infection in skilled nursing facilities. Endemic, which are regularly found among a particular people or in a certain area, such as urinary tract infections, respiratory infections, COVID, skin and soft tissue infections. Also, epidemic, gastroenteritis, which is a widespread occurrence of infectious diseases in a community at a particular time. Of course, pandemic, epidemic, COVID, gastroenteritis, influenza, and certain skin infections such as scabies. Most common respiratory infections, is pneumonia. It's the leading cause of death in nursing home residents and the primary reason for resident transfer to the hospital. It can also manifest in the elderly with atypical signs and be very challenging to diagnose. Inadequate oral care is a significant risk factor for developing pneumonia. Several studies have shown that not having proper oral care, lack of knowledge and training of nursing aides, and maybe non-compliance, frequently seen with patients with dementia that refuse oral care, can really severely limit their oral care. But studies show it's very important to implement dental care programs in nursing homes to prevent pneumonia. Influenza, really the best advice for influenza is making sure that you have a very succinct annual influenza vaccination program that includes not only patients, but also staff. And having treatments when influenza does strike, such as Tamiflu. The risk factors for aspiration pneumonia include suction use, COPD and CHF, feeding tubes, being bedfast, again, comorbidities, the presence of 2 or more chronic diseases, delirium because it's difficult to diagnose in patients that are unable to communicate. Of course, swallowing problems, UTIs, any mechanically altered diets, a high number of medications, and advanced age. This is taken from the Healthcare Infection Control Practices Advisory Committee. It's a framework for infection control program in nursing homes, and they must include these systems. The infection surveillance, which is the system for ongoing data collection on infections using written nursing home appropriate infection definitions. And also the data needs to be reviewed frequently, at least monthly, to identify trends and report both to administration and oversight committees. Outbreak control, using surveillance data to be able to detect, prevent, and control outbreaks, including wings and floors where outbreaks occur. Having good isolation and precaution policies, they should be developed, and there are some excellent resources out there. Making sure you do hand hygiene, resident care. Again, education, infection control is an entire education upon itself, and the more antibiotic storage you have in your building, the better. And also looking at the regulatory requirements for antibiotic stewardship programs. Again, these are triggers or red flags for care. Before we gave you triggers and red flags for medication errors, these are for cares that are related to medical errors. Again, it's in order of most common to least common, found in skilled nursing facilities. And these are things that you need to look at that you should investigate further when they occur in your facility. Acute mental status change, aspiration pneumonia, family complaint is C9. That is something that really sometimes needs to be looked into a little further than maybe it is. Calling the doctor, if it's one patient that there's frequent calls to the doctor, that's something that you should look into further. Finally, remember, medication errors that result in harm to a patient are usually a cascade of errors. The FAA has always found in plane crashes that it isn't the first pilot error that results in the plane going down. It's the second and third error that ultimately causes a catastrophic result. So in the event that you see one error, you need to stop and try to prevent a cascade of errors. Look at the red flags and the care triggers and make sure that they are identified and also addressed immediately before they continue on. Are there any questions? Hello. Are there any questions?
No. Wait.